This is the first session of Public Health Grand Rounds for the fall season of 2014. So welcome everyone, welcome to the people here, and welcome to the many people who are viewing from across the state in their offices and perhaps even their homes. This is the first of 6 sessions we're going to be doing this year on addiction, recovery, and drug overdose death. We thank the Del Prete Foundation for sponsoring this series. And in a minute, I'm going to be introducing Dr. Tracy Green and Ian Knowles, who will be speaking this morning. I want to just take a second and remind everyone about the seriousness of the current epidemic. As of Tuesday, in Rhode Island, we've seen 142 apparent drug overdoses in 2014 alone. We've seen 142 likely overdose deaths, 1,047 uses of Narcan by EMS, and about 250 people treated in emergency departments across the state. So not only do we have 142 likely deaths from this disease, we've been lucky enough to have almost 1,250, almost 1,300 Rhode Islanders saved by the actions of Rhode Island's health professionals. And this has occurred despite considerable media attention and the focus of the medical community and the hard work of all of you. So this is still a major crisis and still needs continued effort by everyone in the state. We are very lucky to be joined this morning by Governor Lincoln Chafee. His presence here underscores his understanding of the severity of the issue and his commitment to solving this crisis. In March, when the numbers became apparent, he convened senior members of the cabinet and directed us to do everything we could to work hard together to get this solved. He went with us to the Northeast Governor's meeting, and after that meeting, he pushed to increase that small task force of people to what is now a task force of 40 people who have brought together many institutions and organizations and gotten us focused on addressing this very serious problem. So thank you, Governor Chafee. Thank you for being with us, and welcome.
Well, thank you, Dr. Fine, and thank everybody for being here. I just want to extend my best wishes for the work you're doing. And as Dr. Fine said, 142 deaths just this year alone. And these are known, in most cases, people that experience with drug use. And so that the fact that they're dying and they've been in this unfortunate circumstance for a number of years, the message out there just has to be, many, many messages, but certainly one for the users. It's just you can't trust your dealer now. And what's happening out there, all of us together trying to address this. 142 deaths, just unacceptable. And so I just want to pledge my support for everything you're doing. And it's a collaborative effort across all the governors, all the northeastern states, even Dr. Fine with our Canadian partners, working with them, addressing some of these issues. So it's a challenge that we want to embrace with all the energy and efforts possible. And so I want to thank you for being here, and the work continues.
Thank you, Governor, for your leadership and your support and your encouragement to all of us trying to address this very serious problem. It's now my great honor to introduce 2 people, Dr. Tracy Green and Ian Knowles. Dr. Green graduated from the Yale School of Public Health with a PhD in chronic disease epidemiology. Her distinguished dissertation was entitled Substance Abuse, HIV Infection, Medication Adherence, and Mortality Among a Cohort of Aging U.S. Veterans. She serves as an assistant professor of emergency medicine and epidemiology in the Warren Alpert Medical School of Brown, and as director of public health research and methodology of Inflexion Incorporated in Newton, Mass. Her research focuses on drug abuse, addiction, and injury. Even more important than her distinguished achievements from my perspective is the way she has been a teacher, mentor, advocate, and spark plug, getting us to look at and think about this very serious condition. She taught me, along with Richard Asinoff, about the importance of this, and really held our feet to the fire until we attended to it, and hopefully will continue to hold our feet to the fire until we get to zero, until there are no more drug deaths. Ian Knowles has also been a mentor and friend. He serves as project director for RICARES, a grassroots alliance of people in recovery, their family, and their friends. We'll start with Dr. Green.
Great. Thank you very much, and thank you to all of you in the room who have joined us here for the first of this amazing session of presentations and grand rounds events on the focused problem of addiction, prescription drug abuse, and overdose in Rhode Island. Some of the goals of today are really to try and describe the burden of drug abuse in Rhode Island and the nation, to identify population subgroups that are most affected by drug abuse and most likely to experience drug overdoses. Thirdly, to list factors that are underlying the disparities in that burden of morbidity and mortality associated with drug use, and to outline implications of these trends for the structure of healthcare in the United States and perhaps how you practice your medicine and pharmacy. As an epidemiologist, I don't treat any one human, I treat populations. I look for patterns in those diseases and look to ways that we can maybe prevent, control, or perhaps even avoid in the first place the diseases that of interest. For me, that has been drug abuse and addiction, and more recently in the area of injury prevention and poisonings or drug poisonings. I focus mostly on data, again, at that population level. So in this talk, I'm going to try and call out some of the data sources that are particularly important and useful. Additional speakers will definitely preview intervention points and things that hopefully I'll be talking about and will be reiterated and give you some additional tools. So first, to start off, though, I wanted to make sure that we define an important definition. That's prescription drug abuse. This involves use of medication, usually by self-administration, in a manner that deviates from medical, legal, and social standards. It encompasses non-medical use, both misuse of medication that's prescribed and abuse of prescriptions and other drugs that are not necessarily prescribed. It's overuse, underuse, and it causes the kinds of burdens that we're going to be speaking with you about. But I'll be using them interchangeably, just so you know. I'd like to start with some data from the National Survey on Drug Use on Health, from the Substance Abuse Mental Health Services Administration. These data from 2011-2012 are the most recent that we have to look at some of the substances that are being used nationally. You'll see here at the bottom labels that indicate that the national northeastern states and then Rhode Island reflect a high burden of alcohol use, binge alcohol use, that's excessive use of alcohol in settings, 4 more or 5 or more for men and women, and illicit use, that's illicit use of any drug. And as you can see across the board, that New England ranks higher than the national average for alcohol use, binge alcohol, and illicit drug use. And Rhode Island, unfortunately, also tops the northeastern states in that respect as well. So in addition to the National Survey on Drug Use on Health indicating illicit drug use, alcohol, and binge use, we also have non-medical pain relievers. So past month, illicit drug use in the US and the New England states, diving into our New England area, we can see that Rhode Island in particular has nearly double the national rate for illicit drug use. We also can see that the Rhode Island community, if you were to remove marijuana use, has the highest illicit drug use per capita in the country. Diving down into the non-medical pain reliever use, because this is an area that we've seen extraordinary expansion over the last 10 to 20 years, that by age group and by state, you can see that, again, Rhode Island exceeds the national rates and the rest of the New England states in the ages 12 and over use of non-medical pain relievers, as well as for the age groups in particular of 18 to 25. Interestingly, that younger age group, the 12 to 17, are actually not as affected and similarly affected as our neighboring states. But somehow as they age, we seem to lose them. But when we look at also some of our treatment episode data sets from the Substance Abuse Mental Health Services Administration's data sets, we can see over time why we have the cause of concern in non-medical prescription pain relievers. And that's the increase in these data from 2000 to 2010, explicitly in the admissions associated with the primary drug of abuse of other opiates. Pretty much for across the board for all other substances, we see a stagnating rate or actually a downward trend, for instance, in cocaine. Similarly, in emergency department visits for non-medical use of prescription pharmaceuticals, the Drug Abuse Warning Network, again from SAMHSA, generated data from 2011. From 2014 to 2011, we saw that ED visits increased by 128% for misuse and abuse of these substances. Clearly, these reflections indicate that use, misuse, treatment, and emergency department visits have an enormous burden on our health system nationally, regionally, and locally, to the point where CDC has declared this problem an epidemic. I wanted to dive into one particular year in 2010 and to call out the excellent work of a colleague of mine and former student, Mike Yokel, who's now at Stanford Medical School. And in his JAMA Internal Medicine article that is in press, we analyzed data from the nationwide emergency department sample, which is from the Agency for Healthcare Research and Quality, a data set that reflects emergency department visits in more detail than perhaps some of the previous data could indicate. Those 135,971 weighted ED visits for opioid overdose reflected some important trends. First and foremost, I think the cost-effective piece. $2.2 billion in charges in 1 year can be associated with this particular health problem, mostly to the hospitalized, the ICU and admits associated with this disease. The characteristics of the visits indicated that 97% of those overdoses were accidental. They're unintended poisonings. The mean age of this population was about 40 years old. 51% were male, which is slightly different from perhaps other trends, indicating that maybe, especially with cocaine and other illicit drugs, we see a more male-dominated health problem. This is more evenly distributed, with men and women being affected by overdose. 24% were uninsured, and 45% were treated and released. Thankfully, the mortality rate was 1.4%. So if you made it to the emergency department, you were more likely to survive. And indeed, as we look at some of the comorbidities that were detected at these ED visits, we can see that there's a differentiation between the non-prescription opioid overdose and the prescription opioid overdose. In particular, the ICD codes for mood disorders, circulatory diseases, and chronic pain diagnoses were differential for overdoses that were prescription opioid involved versus those that were non-prescription. This is clinically meaningful and important for the kinds of co-indications and morbidities that we would see in patients who are very high risk of overdose. I also wanted to look at, re-examine the NISDA, the National Survey on Drug Use on Health data, where they ask the individuals who live in a non-institutionalized setting in a home about the source, if they're non-medically using a prescription opioid, what that source is. A lot has been made of, it can become, people get it from their friends and family, and that's really the only source. In fact, dealers, and dealers could be your friends and family as well. Unfortunately, with this particular drug, it could be your doctor as well. And the data sets the data from this data set reflect that people who use prescription opioids without a prescription initially do get them from friends or relatives for free. And that as their days of use increase and the severity of their dependence and unfortunate addiction increases as well, so do their risks, as we know. Those prescription opioid sources expand as well. And quantifying that, my colleague Chris Jones, who's now at FDA, indicated that about 27% of the people who still report non-medical use of prescription opioids indicate that they still are receiving that prescription from their own doctor. Not necessarily doctor shopping, but from their one single doctor. They also were purchasing from friends and relatives. Approximately 23% indicated this, as well as drug dealers or strangers. So as those, this reflects to I think the public health community that we have multiple sources and multiple places where diversion or obtaining these medications may be taking place, and those that are highest at risk of overdose are as likely to get them from a doctor's prescription. as an illicit source. It also suggests that doctor shoppers, as we detect them in our system administratively, it may indeed be at greatest risk for overdose. So how do we get to this? How do we get in this pickle? Well, some of the factors that we think about that might be contributing to these increasing trends in prescription opioid abuse are, broadly speaking, the aging population. We know that the baby boomer generation is the oldest as an aging cohort, is the cohort with the highest illicit drug use prevalence in their lifetime, higher than all previous cohorts. This aging, both the aging cohort as well as the aging population in age, as you age, the prevalence of chronic pain and painful conditions are more highly indicated, providing a larger source of and pool of prescription opioids. I call out in particular that Rhode Island's age distribution is one of the oldest. We purposefully have a lot of prescription opioids circulating in our population. This is something we have to embrace, deal with, and mitigate the risks of. Widespread use of prescription opioids for treatment, as you all have been seeing, for chronic pain, and also the availability of other co-prescribed CNS depressants, in particular benzodiazepines. This state in particular has one of the highest, if not the highest, benzodiazepine distribution rates in the country. The co-availability, not just co-prescription, but the co-availability of these drugs makes it more likely that they're able to be combined. That synergistic effect increases the risk for overdose. As well as that endemic, as you saw, substance use, especially alcohol and binge drinking, that tend to increase the risk for overdose in the population. Those social norms are something we need to address. But access and supply are actually only about 60% of the problem. Not to say that it's not important, but supply is only 60% of the problem. The other 40% suggests that our demand and our harm reduction efforts and more structural things that we can do through policy and through education are really critical if we're going to eradicate this problem from the population. And indeed, that access to health care that's associated with our greater community level availability has been called out, especially the per capita, and this is an iatrogenic effect. The number of healthcare available prescribers in the community actually do contribute to, in a palpable way and quantifiable way, abuse trends. In particular, the number of pharmacists and the number of dentists. This isn't to say that we don't want pharmacists and we don't want dentists in our community, but it's part of our risk, and it's part of the acknowledgement that we, all of us in the community, all of us here, play a role in the risks that we are creating, and therefore we can play a role in the prevention of its harm. Those social norms and expectancies of pain relief, much has been made of the norming that you expect to come into your doctor and be prescribed something, gosh darn it, I want to have something to take this pain away right now. And the idea that we need to shift some of those social norms and refocus our expectancies is something that we have to work on more generally. The higher potency of some of these opioid agents, in particular, the long-acting and extended release, has been focused on, made a big focus for FDA. That's certainly playing a role. And the limited medication-assisted therapy that's available in the country, less so in Rhode Island, but certainly a place where we can always continue to work. In epidemiology, we think of the triad, if you will. We think about what are the causal models, what is causing, not just correlating, but what is causing these problems. To make it a little bit easier, we tend to break it into the agent, the host, and the environment. To think about the patient, the clinician prescriber, the setting, and the drug. So what is it, and how can we try to reduce the risk of abuse, addiction, and overdose? The indications suggest that, and data do indicate that certain drugs that have a faster onset of action, or they're used in a way that is, for instance, if they're administered by injection, they do get to the brain faster, and they are more likely to be abused. The host, the individual, whether there's a past history of substance use disorder or use in non-prescribed doses or for other indications, self-medication, other ways of understanding how the host could be contributing to this. And then finally, the environment, how much over-prescribing is normed, how much under-prescribing is normed, whether PMP exists and that availability. But is there hope? I think that's the problem. With all of this amazing burden of disease and death, is there hope? And the evidence indicates that there are treatments available. We can see that methadone, buprenorphine, and naltrexone are indeed available. The benefits of methadone maintenance therapy are not singular, but numerous, and they reverberate not just for the patient, for the family, but also for the community. Reducing risks of heroin use, overdose, injection drug use-associated diseases, mortality, criminal involvement, and improving social functioning, pregnancy outcomes for those who are pregnant, and stability more generally for the person. We see the similar effects for other drugs and medicated-associated therapies, buprenorphine and buprenorphine naloxone. When we can expand to other communities and other countries, have given us pause. I think these data come from the United Kingdom, indicating that the probability that treatment is reduced and the average mortality as people stay in treatment, a larger access and a larger pool of medication-assisted therapies, in this case methadone, and in the case of France, through primary care providers and all prescribers, buprenorphine without any limits. That result has eradicated heroin overdose in the country of France. This is, the Europeans have provided us a model of hope, I think, in terms of thinking about treatment availability and access. In the United States, unfortunately, we have the exact opposite trends, where we have not just increased overdoses, treatment admissions, and availability of prescription medications, landing us in an opioid epidemic. These data are from the national data from the CDC, indicating that drug deaths have expanded and primarily been driven by prescription drug abuse. Those trends are not looking like they're going to be turning around anytime soon. The risk factors for unintentional opioid poisonings I like to think about as event-related, because this is something that is an acute injury. It's one that we can study in a very close period of time. It potentially happens more than once if it's not fatal. So how can we learn about the event? It's not just the person, the place, or the drug, but what is it that's happening in time? Indeed, when we look a little closer, what we see is individuals who experience overdose are not just more male or more white or more this or more poor. They're happening to be going through a period of time in their lives where there's an extraordinary change. There's transition in their psychic state. There's combining of drugs in a particular way, or in the case of prison, hospitalization, probation, parole, or detox, there's an extraordinary change in the way their body can metabolize the drug that they're taking in. That instance is a change in tolerance in their body's ability to use that opioid, either in combination with other drugs or the opioid alone. By studying those instances, those events, we can better understand and prevent. So if you treat patients who are coming out of hospital and they have been opioid dependent, you are rotating them from a different drug, a different opioid to a stronger one. If you're starting them on methadone, if you're taking them off of methadone, if you know they've just gotten out of hospital and after being opioid dependent for a long time for chronic pain, if they're coming out of detox or residential housing, or they're just going to go cold turkey because, gosh darn it, they've had enough of this. All of those instances are ones that provide a change in tolerance that will put them at extraordinary risk. If you treat high-risk patients with hepatitis C or HIV or a metabolic disorder like diabetes, you know that if you're also co-prescribing opioids, their body might not be able, in one instance or another, and we don't completely understand why, not be able to take it in and metabolize it as quickly. In those instances, not populations, not people, it's not a risky drug or a risky patient, it's a risky situation. It challenges us to think better. How can we then reorient our systems of care to detect instances of risky situations? What we're left with now in Rhode Island, thanks to Dr. Stanley and to the efforts of Dr. Fine and others who have contributed to these data before you, are an unfortunate collection of victims that didn't make it through that injurious event successfully. From this period of depicted in the graph from 2009 to first quarter of 2014, you can see an extraordinary rise in the state's drug overdose rates. The lines here indicate, in particular in the yellow, medication or prescription medication involved overdose deaths. The black lines are the illicit drug use trends, and the combination of overdoses that involve, these are unintentional, accidental overdose deaths, that involve both an illicit and a prescription medication. The trends, particularly lately in the last 2 years, have shown an upward trend, in particular on illicit drugs that have created the epidemic that we have here. When I started this work in 2009, in Rhode Island, 2/3 of the deaths were prescription opioid involved. Today, in 2014, 76% of those deaths are illicit drug involved. We have an acetylfentanyl outbreak about this, spring of 2013, and one at the beginning of the year of illicit synthetic fentanyl that also contributed to that. The potency of these drugs on the illicit drugs have made their mark. And we need to be prepared and with different ways to avoid the deaths that are occurring. These data come from Inflection, where I do work as the Director of Public Health Research and Methodology. We collect real-time data for post-marketing surveillance for FDA and abusable substances. We also collect it for illicit drugs. These data are reflected 2009 to 2013, a similar time frame that you just saw for Rhode Island. This is the orange is the past 30-day use for people who are coming into drug treatment. So past 30-day use of heroin, and initiation in the past year of heroin use at the national level. This is a stratified random sample of 304,596 individuals, showing extraordinary increases in parallel, both past 30-day use and initiation, recent use of heroin for people who had not been using before. These trends are disturbing on a national level. And when we think about it for Rhode Island, the heroin, the prescription, what's the deal? Why do we have one and not the other? The DEA can provide us with some good trends here, showing us indeed that we have a double trouble. We have not only controlled substances these are reports from the DEA drug threat assessment, so this is narcotics investigators who report on a regular basis what are the drugs of abuse and what are the threats in your community. From the New England area, we can see that both we have high rates of sorry, it's hard to see that Shannon left the meeting. Sorry, Shannon. We have high rates of indicated of controlled substances or prescription opioids, as well as high rates of heroin availability. So availability of abusable substances that can be interchangeable in the community is landing us into the trouble that we're in. The high-risk populations, and perhaps this is a reiteration of what I've been saying before, but for prescription opioid overdoses, are the list that the CDC pretty much puts forth, indicating that men, whites, middle-aged persons, that is 35 to 54, people taking high daily doses of opioids, this is quantified as a morphine equivalent unit, people who doctor shop, people using multiple abusable substances, demographically people with lower income or living in rural or non-urban areas, and people with substance use disorder or behavioral issues. This epidemic, as you saw in the past 2 years, is evolving very quickly. And because of that, the asterisk components here, I don't know if they're going to stand. The demographics will shift very quickly. A little humor here. $20 if you know what this is. Rectal tobacco administration during the 1700s in Amsterdam. This was the standard of care. If you were a drowning victim in Amsterdam, the first city that gave us CPR and rescue interventions to revive individuals who were dying of having fallen in the canals, a serious epidemic actually in the enlightened city of Amsterdam. This would have been used as well as bloodletting. And humor aside, this was stimulation, right? It was new from the New World, tobacco, very exciting, but also was part of the practice-based medicine. It worked. Well, so then we should keep doing it. It also was added to a set of other evidence-based and practice-based interventions, such as warming the victim, breathing into them, into their lungs, and reviving them. That was the first use of CPR. In addition to those interventions, though, or instead of these interventions, we have for overdose the miraculous drug. This device and this medication is the leading medical intervention for the pre-hospital setting to reverse opioid overdose. This is the most effective medication for this, for both diagnosing as well as treating opioid overdose. It's available in the form of naloxone hydrochloride is the chemical compound. It's an intranasal or an intramuscular. It can also be intravenous or subcutaneous, but in the pre-hospital setting primarily, especially with laypersons, as an opioid antagonist, it reverses the respiratory depression that causes the overdoses. And we also tell people, of course, to call 911 to have an EMS and professional administer that medication, or now a law enforcement if you live in Rhode Island, and rescue breathing, the same rescue breathing that was advocated in 1767 in the cities of Amsterdam. Naloxone works explicitly and very effectively by reversing opioid poisonings. It competes for that opioid receptor and knocks any of the opioid or heroin off the receptor in the brain and allows the individual to start breathing again. In this way, it has been used for 40 years as it's no longer a patented medication, and it's an integral part of the drug overdose prevention and responses that this state, some of our data and this state have really embraced. And really to refocus as we think about the implications for public health on realigning our efforts to really think about, instead of just supply, if it's 60% of the problem, what else can we do? What else do we need to do? How else do we have to reorient? To think about demand efforts, supply, harm, and the structural interventions. I'm just going to talk a little bit more about naloxone because we have been actually a national leader in this effort. The data from Project Lazarus in North Carolina, as well as Massachusetts to our north, reflect that we can actually vaccinate a community against overdose. In this effort, what we need to do is distribute naloxone at a rate that will actually reduce the rate, and that we increase the likelihood of overdoses being reversed and reduce mortality. The likelihood of us eradicating drug addiction, drug abuse, or even overdose completely, but we can work a lot closer to the effort of reducing mortality associated with this health problem. The data published in BMJ by my colleague Alex Wally showed a 50% reduction in overdose mortality in communities that had higher coverage, that is, higher distribution of community-based naloxone. In Rhode Island, and I think that these are not just groundbreaking on a local level, but in June I spoke at the White House. In July we had a presence at the U.S. Attorney General's office talking about our efforts with law enforcement. These are, we are, I think, trying to build a focal point for naloxone distribution and really rethinking how to use this medication in a way for public health and for all the individuals to get to that event, not to the person, not to the dose, not to the drug, but the event to reduce it from occurring. So those community-based efforts include naloxone at recovery community points, the Pony through the Miriam Hospital and Anchor Recovery, through regulations that were created by this health department, emergency regulations allowing any Rhode Island licensed prescriber or pharmacist. So prescribers can become pharmacists and pharmacists can become prescribers with respect to naloxone, not to other things, to naloxone alone. And the emergency departments to this day have just begun with Recovery Coach, is a really exciting project at Care New England as well as at the Lifespan Hospitals, EDs. Through the BHCDH state-funded drug treatment programs, the residential and the detox programs now have naloxone, as well as at the VA and at Butler Hospital. And we're just beginning more prison-based work because of that the change in tolerance, that high-risk population at that high-risk point. And most exciting, I think, through bringing additional partners from our public safety community, the state police and different municipalities all around the state. We've been able to evaluate almost 200 of those state police and municipal law enforcement, as trainings have continued with almost 600 individuals around the state to both learn about overdose prevention, what police and state police can do, and how to carry and administer naloxone, and aftercare reflections. We have a really exciting law, maybe you know about it, it's called the Good Samaritan Law. It passed in 2012. The website linked down below, you can find the text of that law, but it allows and it encourages people to call 911 in the instance of a suspected drug overdose, and it removes from partial immunity from drug-related charges for the caller as well as the victim. This is to encourage people to call 911. There are multiple states with interventions like this. And this policy innovation is one that we don't have a ton of evidence for, but a lot of face validity, if you will. Interestingly, perhaps you saw last week's JAMA Internal Medicine article that looked at medical marijuana laws across the country and found a 25% lower mean annual opioid overdose mortality rate in states with medical marijuana laws. Fascinating and controversial contribution to the science here, but I think as a policy innovation, we have indeed a medical marijuana law, as you all know, and to look at this as an area where we can think about how policy could potentially help us in a very low cost, perhaps high impact way. And I can't have a talk around prescription and addiction, prescription opioids and addiction, and not mention the prescription monitoring program as an innovation that has actually very little evidence, especially for a mortality impact, but a growing evidence base and one that deserves time, attention, and care. I think one of the things that we've seen around who uses the PMP is there are just so many people. It's not like a stethoscope. Like, you're the doctor, you use a stethoscope with the patient. You're not going to go give it to law enforcement and use it, and you're not going to give it to the pharmacist and use it. Like, you are using this one tool. The PMP has many potential uses, and people see in it different things for different uses. I've tried to capture that in this figure, and it's the source of my current CDC grant looking at PMP use and its impact on public health outcomes. But as prescribers, and we've done now 2 surveys, one with prescribers and one with pharmacists, to ask people how they use the PMP. I think this is where we have to spend more time. How do we use the PMP, not just to affect supply? There are data suggesting that use of the PMP shifts prescribing. It shifts what drugs you prescribe. But the data are also inconsistent on reducing abuse, death, and unfortunately we're starting to see in some states a shift towards that heroin. So as we move into the next generation of PMP, both data and use, we're looking at what other things, how can PMP use by prescribers, especially, promote drug treatment referral? In our survey a couple years ago, it was published in Pain Medicine, looked at how do clinicians, especially in Connecticut and Rhode Island, actually use the PMP when they have concerns about diversion. And indeed, we saw more initiating of referrals for treatment, additional counseling and monitoring. Clinicians want to use these clinical tools as clinicians, not as law enforcement individuals, to encourage and support additional resources for treatment demand, as well as for the next round, harm. How can we use PMPs to bring in our work with naloxone, bring in our work with treatment, and comprehensively address this problem with those tools? In this way, we can think about primary prevention, secondary prevention, and tertiary prevention to prevent initial exposure. Maybe this patient doesn't need an opioid in the first place. Oh, they need the opioid. How do I mitigate the risk of them having a problem? Oh, they've had a problem. How do I keep them alive and get them properly into treatment? Each of these are mechanisms, and there are a lot of things you can do. This is the last slide, and I'd like to indicate that these 4 tools, the PMP, Rhode Island at ripmp.com, to register and encourage you to use the PMP, in particular counseling patients on safety and on medication, on overdose risk, and potentially on treatment referrals, and for familiarizing yourself with the tools that are, the practice tools that are on the website for the health department. To use a new pilot program, the Physician Consult, for assessment and treatment referral if you're not comfortable necessarily treating a potential addiction or diversion concern. You can call this line, the Bridgemark line, and have a consult and assessment within 1 hour's time. So the patient does not need to leave your site to have an understanding and potentially connect them with care. If you feel more apt to treat within your own clinic population, becoming a buprenorphine prescriber is certainly an opportunity that you can embrace. And I'd like to lastly indicate that encouraging alternative chronic pain management strategies like the Living Well program, you can find out about it on the health department's website, as well as medical marijuana based on the data that we have so far, and alternative ways and complementary methods for treating chronic pain: chiropractic, acupuncture, massage therapy, and physical therapy. The first 3 of which, if you have Medicaid patients or treat Medicaid patients, can be paid for by Medicaid. I should encourage you to talk to your managed care providers, organizations about that. And lastly, to refer people to access naloxone or talk to their family members or caregivers, to go to a Walgreens or go to a CVS to request a naloxone prescription. This is covered by your insurance. At this point, you can pay out of pocket. Resources for if you want to become a prescriber can be found at Prescribe to Prevent. That's prescribetoprevent.org or .com for both prescribers and pharmacists for more information. Thank you very much for your attention, and I will hand it over to the next step.
Now perhaps you understand why we like epidemiologists in the Department of Health. That was a great presentation. Thank you. Before I introduce Ian Knowles, I just wanted to take a moment to particularly thank a number of people at the Department of Health who have really worked hard with Tracy and others to try to stop this epidemic. They include Jen Andre Kozol, Dr. Jim McDonald, Dr. Christina Stanley, Peter Agasta, Mike Samoli, Samantha Viner-Brown, and Dr. Bandy, who have all been tremendously helpful in trying to get this stopped. So let's give them all a round of applause. Now it's my great pleasure to introduce Ian Knowles. We thought it was tremendously important to have the voice of people in recovery heard when we talk about prescription overdose and other overdose death in this epidemic generally. Ian's been a friend and a teacher, and I think as you'll hear, there's been tremendous bravery that comes out of folks in recovery who have taught the rest of us a tremendous amount. Thank you. Ian.
Good morning. Thank you, Dr. Fine, for insisting that recovery be present. I'm fairly used to speaking to groups, and I find myself a little more anxious than usual this morning. I think it's probably because everyone in the room is smarter than I am. So it's a privilege to speak with you this morning, and my intent is to hopefully give you some useful insights and information. So I am a person in long-term recovery, and what that means to me is that I haven't used alcohol or illicit drugs since February of 1985, and as a result, my life has become unimaginably better. And one of the reasons that we in the new recovery movement say this is that we all do stereotypes. And my guess is that your stereotype of what a drug addict or an alcoholic looks like is not someone who looks like me. I am a drug addict and I am an alcoholic. Fortunately for me, my addiction is in remission. It's difficult for many people, generally, and even in my experience in the medical profession, to accept that addiction is a chronic, recurring biomedical condition. Because it's probably the only one that starts with a voluntary act, making a decision to drink alcohol, to use marijuana, hallucinogens, cocaine, and or opiates, all of which I initially chose to do. But when I had my first drink, when I was a junior at Barrington High School, I had no idea, I had no intention of becoming addicted to alcohol and other drugs. I didn't have a clue. And when I continued my use into early adulthood, I also didn't have a clue. I just liked to party and get high. Of course, with addiction, it eventually always gets to the point where choice is no longer an option. We do know that in every generation, roughly 10% of the population develops significant problems with a substance use disorder. And that 10% cuts across age, gender, race, ethnicity, socioeconomic status. So a couple of things that I hope will be useful for you in your working with that 10%. About 25 years into my addiction career, I needed to have a cholecystectomy. So I went to Miriam Hospital, and the resident that did my pre-op workup asked me what I had had to drink the night before. I told him, well, probably 3 or 4 quarts of beer. Of course, I minimized my use. We all tend to do that. Now, as I was lying on the gurney, waiting to go into the OR, my record was placed on my stomach. So I picked it up and read, and the admission note started, "This 42-year-old alcoholic." I was enraged. What did he know? How could he say that about me? Now, over the years, I had self-referred to a couple of psychiatrists. I was dissatisfied with my life, I was dissatisfied with myself, and I thought that therapy was a solution. They both diagnosed me with depression. Now, my daily substance maintenance dose was a half a case of beer a day. A very a serious ingestion of a powerful central nervous system depressant. So it's kind of not surprising that I was presenting with these depressive symptoms, but I had never had any symptoms of depression prior to my first use. I've never had any symptoms of depression since I've been in recovery. What that resident at Miriam did was he planted the seed for my recovery. He asked the question. You all have the credibility to do that also with your patients. Many of us don't use alcohol and other drugs to deal with corollary issues. I never suffered any trauma. I never had any mental illness. Well, my wife is a psych nurse practitioner, and she will occasionally accuse me or tell me that, when she's frustrated with me, tell me that I'm schizoid. But I'm assuming that's an expression of frustration and not an actual diagnosis, I think. But my addiction was not caused by a character disorder, was not caused by a lack of morality, not caused by a lack of willpower or self-discipline. Those are the things that my addiction took away from me. I was a regular happy kid until my first use. I've been a regular, happy, well-functioning adult in recovery. Often, simply the cessation of use and entrance into active recovery mitigates many issues and problems. A common and relatively unacknowledged factor that works on people with active addictions is a strong sense of shame. Shame at who they are, at what they've done, and what they continue to do. This is a major source of the rationalization and denial that are common, and you need to be aware of that. A critical task in early recovery is addressing and getting rid of that shame. Finally, there's been a lot of research and developed knowledge about addiction and treatment. However, although there's an emerging neuroscience of recovery, we know very little about what factors contribute to long-term and permanent remission of addiction, that is, sustained recovery. Until the science catches up, right now the best source of knowledge about long-term recovery is the lived experience of those in long-term recovery. We are accessible and available at RICARES, ricares.org, and at the Anchor Recovery Community Center, anchorrecovery.org. I just want to say that addiction in some way touches most of us. And if you have a family member, a member of your extended family, a friend who's struggling with addiction, I want you to know there's hope. There are over 23 million people in America in addiction recovery. There are thousands in Rhode Island. I'm in addiction recovery. There is hope. Recovery is a reality. Thank you for listening to me.
Thank you, Ian. I'm going to ask both speakers to come up as we take questions. I'm going to try to simply restate questions from the audience so folks who are looking at this as part of the webinar can hear the questions. Anyone?
Since many of these patients initially get into this trouble through chronic pain problems, and that the one evidence-based therapy for chronic pain management, which is the multidisciplinary pain treatment type of centers, are almost non-existent in this country. What can the state do from a policy standpoint or legislative standpoint to help advance the availability of treatment to get at the initial problem?
I'm going to restate the question in general, and I'll try to answer it and ask you guys for your contribution. I would request that people direct questions to the speakers instead of to the Director of the Department of Health. The question simply put is, the best approach, much of the gateway to addiction is chronic pain. The best evidence-based approach to chronic pain is a non-narcotic multidisciplinary chronic pain treatment center. What can the state do to create some? Because we don't really have any in Rhode Island at the moment. Do you guys want to answer first? Tracy?
I will let Dr. Fine talk about the sort of policy aspect and approaches, but there certainly are techniques that clinicians could use employing CBT, which is definitely an evidence-based approach, as an augmentation, or working through interventions that could help, or referring to an individual a professional who might be able to help with a CBT-based approach or alternative pain approaches, is definitely something that's available, either in addition to the opioid or not. So that's one way. And then sort of backing up, if it weren't a pain indication but more recreational use for youth and children, there are definitely evidence-based approaches that have been emerging more recently for universal precautions that involve school as well as parent involvement, that are actually showing evidence of helping with prescription drug as well as alcohol as well as illicit drug use and reducing those trends. So there are lots of different ways we can get at reducing the transition into addiction and to other opioid problems.
And from the policymaker perspective, the state has traditionally not been in the business of building new facilities. It has been traditionally in the business of waiting for the market to respond, as we have more of a health services market than we do a healthcare system per se. So I think in order to address that, everyone here has a role in talking to their legislators. If folks here think that it should be different, and persuading the legislature that maybe it's time to think different about this issue in particular.
Yes, I had a question for Tracy. You provided those stats with medical marijuana and the opioid overdoses. But you didn't put it into any context. Do you believe medical marijuana is a form of pain management which reduces the use of opioids?
Question is, for Dr. Green, do you believe medical marijuana is a form of chronic pain treatment which reduces the use of opioids?
There is a body of literature indicating that medical marijuana can be helpful, especially for pain indications. That's part of the impetus behind the medical marijuana legislations that have passed in so many different states. And there are emerging imaging studies and otherwise indicating that marijuana can be helpful in the treatment of pain, and especially the psychic pain that might be bringing people to prescription opioids. It's unclear the mechanisms, sort of the state medical marijuana law is in place, and then we have lower overdose rates. How it works at that individual level or at a societal level is still the source of fruitful research for sure. But there are definitely a number of clinical studies suggesting that medical marijuana can be helpful for the treatment of chronic pain in particular indications. So I encourage you to reach out to that literature as well as to the JAMA Internal Medicine article and the editorial that actually was very well written that accompanied that article. I can put that or circulate it if you'd like to.
Thank you. I think we have time for one more question. Bill?
Any idea what's driving the increased interest in heroin? Is it simply a supply issue, or is it the drug of choice? So what's going on with heroin?
What's driving the increased use of heroin?
I'd love to ask the cartels that question. Their opportunity, certainly opioid-dependent people moving and having chance, or potentially there are a number of hypotheses, and myself and other scientists are definitely thinking about what are those hypotheses, how can we test them, how do you even get data on illicit drug use, and availability of heroin from the street, from prices, from DEA, from where do you get that? We do know that the trends in heroin increase use did precede the 2010, for instance. A lot of people have indicated, oh, it's OxyContin reformulation, oh, it's Opana reformulation, oh, it's REMS, oh, it's restrictions on PMP. It could be one or many of these things, but most of those have affected the supply and affected the agent that's being used, sort of thinking about that triad. Very little has changed in, we have more young people or more men or more, the chance of it being purely associated with individual behaviors is not necessarily a clear causal link. But there are definitely a whole host of questions out there that we're trying to test out. But in the meantime, all the deaths occurring, we're sort of trying to get ahead, and thankfully a lot of the interventions for prescription opioids, especially on naloxone, will be effective in the heroin aspect as well. But definitely a source of lots of scientific inquiry. And from what I know, I don't know anybody, or it certainly was that was why we went to the White House to present what we were doing, and everybody's looking around going, what do we do? This is happening, and we don't know why completely, and how to change it.
Yeah.
A couple of other factors are frequently heroin is cheaper than buying illicit street drugs. And the heroin dealers have packaged heroin so that it can be used nasally rather than injected, which is a much more desirable route for initial users.
So thanks to speakers and thanks to everyone for their attendance, interest, and work. Thank you all.